30-year-old female, diagnosed depression, OCD, reluctant to start new meds because of adverse effects with multiple SSRIs and other medications, responding well to CBT. So currently has a history of and continues to have pensive and depressed state of mind. Okay, so depression's her primary symptom. They're working on it in therapy, ruminates, catastrophizes most anything, sometimes turns into a panic attack. So any thoughts or suggestions are appreciated. So a patient with depression, she's got OCD, but it sounds like depression is her main problem. Looks like maybe can't tolerate SSRIs or serotonergic medications. Is that accurate to say? Like, what happens with SSRIs as a class or SNRIs?
She's had side effects with everything that she's had. It's pretty extensive, and she's just afraid to take anything. She just had various agitation and no help from the antidepressants.
Okay. Is it a general pattern of agitating side effects from SSRIs, or are there other side effects that are the limiting factor?
She said agitation was a big thing, complained of physical things such as stomach upset, as I recall. Most of those I didn't do. Those were in the past.
Okay. Yeah, so it's hard because, you know, when a patient comes to you and they have a history of not tolerating a lot of meds, I always want to get the details of specifically what dose they were on for how long. Was it an adequate trial in terms of whether or not to know there was a benefit, or just was stopped prior to that? And also, is there some reason why this patient has, say, agitating side effects from SSRIs? Is she on the bipolar spectrum, or maybe bipolar 2 or something? Or is it like an anxiety response to taking medication? Because if it's the former, I'm maybe just taking it at face value and avoiding that class of antidepressants. Maybe I'm thinking of something like Wellbutrin. But if it seems more like anxiety, then I'm probably doing some CBT around that and seeing if she'd be willing to consider something like a very slow taper. And I probably would go with Lexapro, because that seems to be, in my experience, the one that's least likely to cause agitating side effects. It tends to be more sedating. And I might prescribe a 5 milligram pill and split it into quarters or something like extremely small. Or even if that's too much, finding, I don't know if Lexapro comes in a liquid formulation, but at least Prozac does, Zoloft does, using one that comes in a liquid formulation. And you're essentially doing a behavioral desensitization where, like, for the first week, take 1 drop and then you take 2 drops, and you're just gradually getting them used to the idea of the medication. And I also will counsel these patients on what the nocebo effect is. You know, I'll be like, you know how we've all heard of the placebo effect? Sometimes you get a positive benefit from something and it's just a sugar pill. Well, did you know the exact same thing happens for negative side effects, and that in all of our medication trials that we do in psychiatry, that patients in the placebo group get the side effects they were counseled they would get when they enrolled in the trial. And then it's like, oh, I didn't know that. So I kind of set it in the patient's mind that our bodies and minds can manifest side effects as well. And I emphasize, look, I'm not trying to be dismissive of your side effects, but let's keep this in the back of our head. Just so far when I say that, do you think she's in the like former category, maybe just bipolar spectrum, or do you think it's like an anxiety thing, challenge of an SSRI?
I don't believe she's in the bipolar spectrum. The predominant thing is this catastrophizing and this level of anxiety, and she gets herself worked up. So I've done some exposure therapy. It's worked pretty well, but not sufficient.
Yeah. Based on that, it makes me think more about going in the direction of an SSRI, just because SSRIs can be so helpful for anxiety. And I've had patients like this who are extremely anxious, and sometimes it's like a 6 to 12 month process of getting them to take a medication and doing the CBT, the exposure therapy, working on the catastrophization, other cognitive distortions. Sometimes these patients who are highly ruminative, almost at the OCD level, it's not something that an 8-week course of CBT is going to fix. It might just take some time. So it sounds like I think you're on the right track, and just do more of what you're doing, and also consider, again, I think maybe a retrial of very slow taper of an SSRI. So a question about hiring a virtual assistant, how to find one, incorporate their salary to business expenses. The question I always ask people is, do you need a virtual assistant? Because I know, Yasmin, you're just getting started. What would you be hiring the virtual assistant to do?
Scheduling, billing, things like that.
Okay.
Actually,
So
Practice Q has those features. I guess I'm not sure if I need.
exactly. Yeah. What I would say is that there's quite a bit you can just automate with what Intake Q or Practice Q offers in its software suite before having to hire someone else. Because I'll tell you, having hired many people in my life, just hiring someone is a learned skill. Managing someone is a learned skill. And with any learned skill, you're not going to be good at it probably at first. You know, you're going to hire the wrong person, you're not going to train them right, you're going to have expectations that are too high or too low. You might cycle through a few people. And so you want to really need that before you go in that direction to hire someone. And things like scheduling, you just set up an Intake Q or Practice Q scheduling widget. Patients can self-schedule. If they email you asking to set up an appointment, you can just send them the scheduling link. Patients can reschedule via that scheduling link. And then billing, Practice Q can do that as well. You just have to set it up in the beginning, set up whatever the fee schedule is for the patient, but then Intake Q or Practice Q will bill the patient according to that fee schedule automatically. And then the only thing you have to do is, if a credit card is declined, you know, like expired or there's a fraud warning or something, email the patient credit card off. I'll tell you that I do have a virtual assistant in my practice, and my practice is just very part-time, right? But I wanted one, and what she does is double checks the day before that all the fee schedule for the next coming days appointments are set up properly and that the right amount will be billed. Then she checks to make sure that yesterday's credit card charges all went through, and if something was declined or didn't go through, she'll follow up with the patient with a new credit card auth and manage that. If a patient emails me labs, just lab results from another provider, she'll just upload those to Luminello for me automatically. If I have the patient do an Intake Q form, because I use Luminello for charting and Intake Q for forms. If someone submits a form and I don't want to just go through the seconds of uploading it, she just automatically does it. So when I show up to my email box the next morning, those lower level things have been processed. And similarly, like if I'm upcoming vacation and it may be the vacation's in 2 months, but I had already scheduled a patient during that week, I'll be like, hey, Gracie, so-and-so scheduled when I'm actually going to be taking a vacation. Can you reach out to her and reschedule? So it's nothing that's so difficult, but these little things would add up time. And certainly I'm only paying her what's equivalent to like 30 minutes of my time. So it's more than worth it to do that. But I would say what made that an efficient process for me was, one, being very experienced with screening, interviewing, and hiring, and two, being extremely organized in terms of the processes in my practice, having everything extremely well documented, where all I had to do was say, here's all my already established documentation for everything I want you to do, and now instead of me doing it, you do it. So generally in the beginning when you're starting a practice is not when you want to hire someone, because you're still figuring out your systems. You kind of want things to be already relatively organized before you're hiring someone else to come in, or else it's just going to be more disorganization. Does that make sense, or do you have questions about that?
Yeah, I know in the beginning, but basically, like I want to hire somebody. The reason is I don't want to have a conversation about credit card declinations or the financial aspects, and have a buffer person. So like that's the area I'm not really feeling comfortable.
Well, let me ask you why. What is it about having a conversation about money, or just like, hey, your credit card is declined, that makes you anxious? Or
I mean, the financial aspect of the process is like I feel like it may disrupt the therapeutic alliance. That's my fear.
I hear what you're saying, but I would say that there's no way around, if you are charging people money, that money is going to come up. And it's not realistic to think you can totally avoid those conversations. And I'll say for me, I didn't have assistant for a long time, and it was anxiety provoking for me to talk about money, but I had to kind of get over that and, you know, do the exposure therapy of it, because now I'm able to confidently have those conversations, even if though I don't necessarily have to, and it's no big deal. Like a credit card was declined for a patient, and I could have just waited for Gracie to handle it after hours, but at the end of the session, I was just like, oh, by the way, your credit card was declined. Did you? And she hopped in, oh yeah, sorry about that. I just got to give you a new credit card. I'll email that to you. And I had another patient recently, a new patient, on the call, like the 20-minute call, and she had to check a box saying that she'd already seen my fees, but she's like, oh, at the very end, what are your fees again? You know, but I like, oh yeah, no problem. And I just said them. So there's no way around that money's going to come up. It's not going to be that often, because if you have your fees online, people will see it. Credit cards usually go through, and you can just have a template email. I just have a template email. I don't have to send it out anymore, but when I didn't have Gracie, hi X, you know, I just wanted to follow up about your appointment from earlier today. Your credit card was actually declined. Often this happens when the card expired, or there might have been a fraud warning on your card, so it was canceled. When you get a chance, do you mind submitting a new credit card auth via this link? When you get a chance, thanks so much. And I just take out X and put in their name. It's no other work than that. So I would just say, I know for myself, I made the mistake in the beginning of hiring a virtual assistant to set boundaries and to have conversations that I didn't feel comfortable having. Like, even if it's $20, $30 an hour, they're just an admin person. You can't put them in a situation to say something that you yourself are uncomfortable saying, because the pushback you get from a patient, they're going to get times 100. I was shocked to hear things that patients that I thought were nice would say to my assistant that they would never in a million years say to me. And actually, I found that having like a US-based assistant, a downside is that patients get the idea that someone should be available at all times, versus you just want them to be used to the idea that they have to wait a sec to get in touch with someone. So for those reasons and then others, I would just say it's more of like a internal growth process to go through, rather than to try to outsource it to someone else, because from personal experience of having tried that, it doesn't work.
Okay. All right. Thank you.
Yeah, no problem.
Was just talking about this with a colleague. How do I cultivate like that authority? Like, I want to be collaborative. I want the patient to buy in, and I want them to feel like it's a treatment plan that they can adhere to. But I feel like at times I'm a little bit like kind of overly attentive. Like, okay, does this work for you? And then it kind of comes off as being like, I guess, subservient to some degree.
Yeah, this is something that I know I personally evolved in over the kind of the years of my practice, because when I first started, that's how I was, you know, extra empathetic and sensitive. And then it only took like a couple patients steamrolling me a little where I realized, okay, I got to have a little bit more balance in my demeanor and be able to recognize sooner when I need to set a boundary. So I know for me personally, the first step was just recognizing when it was happening, recognizing in the moment where this is getting pushed a little bit and the patient's spinning. And then sometimes it's just, I don't have kids, but I imagine it's almost like parenting an anxious child. Like, okay, we're just gonna take a deep breath here, you know, so I totally hear you, XYZ, but let me just tell you from experience. I've worked with so many patients who are like you in XYZ ways, but what happens if we do what you're saying right now is that it's not gonna work for XYZ reason. So I'm just asking you, I know you've got anxieties, you came to me for help, I just want you to suspend your disbelief for at least a month, you know, some period of time, if it's like a medication trial or something else. Just work with me, just suspend your disbelief. I can tell you, I've worked with patients like you in this situation, they have gotten better. So it's kind of like reassuring, even little things like my body language is a little more forceful, kind of the way I said it. It's not unkind, but I'm just a little bit more, I lean forward, you know, hand gestures, things like that. So yeah, again, I would just say the first step for me was even just recognizing it. And sometimes in the beginning, you might not recognize it till the appointment's over. And you're like, wait a second, I got steamrolled a little bit. Then it's almost ideal because you can rehearse a little bit. You can rehearse like what you're gonna say, and then, you know, have a plan for saying that at the beginning of the next appointment. Maybe you say, hello, how you're doing? Allow them to say what their agenda for the appointment is before diving into addressing addressing their agenda. Like, I just want to address something that came up from last point. I was thinking about this, and et cetera, et cetera, et cetera, and then say it.
That makes so much sense. That's actually literally what happened. The patient, by the end of the appointment, ended up scheduling somehow outside of my established hours.
Yes, right. That's, yeah. When you find yourself bending boundaries that you're certain you wanted to keep, ask yourself why. And sometimes it's because the patient's pushy or obnoxious, but sometimes it's the patient's so passive or helpless or anxious. You're like trying extra hard to help them, but pull back a little bit. Some patients give you the vibe of like they need to be saved, but you can't jump in and save them. Take a step back, follow your regular procedures and policies and boundaries, and like take a deep breath. Don't make their emergency your emergency, if that makes sense.
It does. Thank you.
Yeah, but it took me years to learn that and many mistakes, so.